For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 3, Episode 8, our discussion of the Innovations in NAFLD Care 2022 series starts now.
This week on Surfing the NASH Tsunami.
The webinar last week, we had an opening session that brought together an endocrinologist with a dietitian specialized in obesity and as it relates to metabolic health. We had a hepatologist present NAFLD patient guidelines and then got a patient response on the NAFLD journey. So we're trying to really bring together different disciplines, different perspectives to get the patient, person on the street perspective.
When I talk to physicians here, you still get those, why should I worry about the liver? On the other hand, we know that it's an exponential risk in patients with cardiovascular disease. So how much does the liver add? And we really want to emphasize the need to do these type of tests, because if your physicians that get the report, but they won't act on it because the knowledge is not there, this is a major burden here, at least in the German healthcare system, where you have less NHS structured pathways. It's the physician has to act on something he receives and convey that information to the patient.
I think the patients are beginning to sense that there is something with fatty liver, and that when they go to their provider, they get falsely reassured that there's nothing going on. And so that just reminds me that we have to do this in parallel. We need to bring the patient awareness, but if we send patients forward to the physicians and they're turned away, that doesn't do us any good.
Week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader, Dr. Stephen Harrison, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guests, hepatology researchers and key opinion leaders Professors Jörn Schattenberg and Jeff Lazarus, as they discuss the year's series of programs titled Innovations in NAFLD Care 2022, which Jeff and Jörn are co-chairing. This week on Surfing the NASH Tsunami.
Welcome, everybody. This will be the first episode of this year that we have not formally made NASH-TAG the focus of what we were doing. Stephen, I'm thinking you might start jonesing about half the way through if we're not doing NASH-TAG. But without getting way ahead of myself in the business section, I will tell the audience that we've had about 40% more listeners in the past 3 weeks than we ever had in a 3-week period in the history of the podcast, which either means this podcast has done something right, or it means that the NASH-TAG content was that exceptional, or maybe both. But I'll certainly give a lot of credit to NASH-TAG. At any rate, with us are three of the people who are, well, Stephen, obviously, who was a co-chair in NASH-TAG, and Jörn and Louise, who were with us, and also Jeff Lazarus. And let me just start with you, Jeff. How are you today?
I'm great, thanks. It's been a busy Monday, as Jörn and I will share, but it's been a good start to the week. Thanks.
So I will tell our audience, so that you can all hold us honest later, that Jeff was regaling us with his tales of having become a media star recently. So we will want to hear, or at least making a lot of media appearances, not to go overboard. So we'll want to hear a little bit about how that's working for the two of you folks. Jörn, how are you this evening?
Good, Roger. Early evening here. I had my dinner because the family's a little earlier than you do that in Spain also. On that side, I'm not pressured, but of course it was a busy week. It was a great start to the year. Again, with some distance to NASH-TAG. Stephen, congrats again to you and the organizers. It fed and it gave energy to move NAFLD, and I'm excited to what is coming up this year.
So, Stephen, how are you through NASH-TAG recovery yet?
I am still surviving on the aroma of NASH-TAG and the positive energy that came out of that meeting. Although I will have to say that I am quite hungry. I'm currently still on Paris time, so it's 7:45 at night, and I'm like thinking I need to be going to bed soon and eating something. Unfortunately, it's 12:46 here in Texas, so I've got quite a long way left to go in my day. But no, just circling back, NASH-TAG was terrific, and it'll be a sentinel event for a significant amount of positive change that will occur this year, or at least I'm hopeful.
So, Stephen, what is the aroma of NASH-TAG?
Think of your favorite grandmother's maybe homemade soup that she made. And, on a cold day, warming up some cornbread in the oven to go with that soup. That's what it smells like. It's a reflection on very, very positive senses, and I think it bodes well for the year.
So, Louise, good afternoon. Good evening.
Yes, good evening. I'm an hour behind Jörn, so my supper is cooking in the oven. I can smell it. Well, we're on food today.
That would not be the aroma of NAShtag, but it would be the aroma of the podcast today. That's good. So something that we know, but audience, you don't until I'm about to tell you this. Next week, I'm actually going to celebrate my wife's birthday, which is something she's been asking me to do with her for several years by taking her away. And Louise will be hosting our podcast, something we've not done before. But she's got a fantastic program lined up, and she'll talk about it a little bit later, and we'll do it. So with all that, why don't we get started? Icebreaker. One piece of good news that has nothing to do with NAShtag over the past week, or one piece of news. I'm not sure I'm going to have good news. One piece of news over the past week that is not about NAShtag, because heaven knows we had enough good news about that. Bold one, go first.
I'll start professionally here. We've had a paper accepted in Hepatology Communications. It's a big population-based study in Germany that looked at prevalence of advanced fibrosis. Now, we took NITs, so there's some uncertainty to that, but the study shows 1% of advanced fibrosis in Germany, in my area here, and it's something that it took us quite some time to get it published and assembled, but it's something that was a big success for me and the team, and we'll see how to implement care for those patients, 1% of the general population in my area with advanced fibrosis.
Well, congratulations on the paper, and good luck to those folks in dealing with their fibrosis. Next.
I'll jump in next. We released a radio show that I was interviewed for on liver health, which is just a general health show in the UK, health radio. So we were talking about fatty liver disease. We were talking about, just more in lay terms, the importance of knowing your liver health and looking at just the easier things to do to try and avoid it. Some of the figures and statistics that are driving through Europe at the moment following the Lancet Commission. So just raising its awareness post-Christmas, and January, as we know, is Love Your Liver Month. So the timing for release was quite nice. So that was quite nice to do, and certainly quite nice to be more general liver health rather than specific to raise awareness.
Congrats. That's excellent. Next.
I'll go ahead. Well, professionally, together with Jörn and discussed on this podcast, I think a month or two ago, we talked about a paper we had called a Sustainable Development Goal Framework to Guide Multi-Sectoral Action on NAFLD through a Societal Approach. Actually, as I read that title, I think it's a bit of a mouthful. But basically what we're looking at is how to put fatty liver disease into the UN's Sustainable Development Goal Agenda. And I just heard from APT that it was the most downloaded paper in the month of December, which I was quite surprised. I'm glad readers of APT, many liver specialists are interested in this perspective as well. And personally, well, I just finally figured out how to check my daily steps. I know I'm probably the last person in the world to figure out where that was on the phone. The good news is I'm walking a lot, almost 10,000 steps a day, except for this past weekend when I went skiing, which was wonderful.
Good for you. Okay, Stephen.
That's terrific. So let's see, professionally, keeping with the theme of transitioning to NITs, they're not a personal win, but I think a society win. There were two papers that came out looking at combination of FIB4 and VCTE to predict outcomes, and then a separate one on FIB4. So again, independently, these don't say a tremendous amount, but corporately, when you include all the data that's being generated, it's beginning to make a relatively bold statement to the FDA. So we are in the middle of summarizing all of that NIT data, and we'll be putting together a white paper and submitting it for publication here relatively soon when I can find the time, since I don't have a fellow to help me write that. I'll be taking on that task myself, at least with the first draft. But exciting to see all the data that's coming out, and it's hard to ignore. And when you can look back and you can have a conversation about other disease states where NITs were brought to bear to change the way we manage the disease. Think of PBC, think of Alzheimer's disease. We didn't have to have outcomes data at the very beginning. We found a non-invasive measure and went with it and still used that measure to an outcome, but it allowed drug development to continue at a much earlier pace. We have a body of data now, a corporate body of data that suggests that we should be able to pivot to that if we can get a loud enough outcry from the collective we. And the we is not just physicians. It's the court of public opinion. It's patients. it's lawmakers, it's everybody involved. I think it's time to pivot.
So that's a great pivot actually into the episode. I'm going to give myself the right not to do an icebreaker this week. I've not had a week I particularly want to break ice about. So we'll skip me and we will pivot from Stephen's comment into the guts of this episode. Since Jeff and Jörn, I might have this wrong, but my sense is that part of the goal for what you're doing is to broaden out the scope of the people who are paying attention, to get a wider audience of more different kinds of people deeply invested. And if so, I think that would align with Stephen's comment about trying to pivot on public opinion. Why don't we just dive in there?
Yeah, I mean, that's absolutely right. And I know Jörn's going to have a lot to say on this, but, I mentioned the whole of society approach to NAFLD and NASH, and that's really from a policy perspective to get this onto the agenda of policymakers, even get it onto the agenda of the UN and WHO. We're not short of ambition at all in where we think NAFLD and NASH should be addressed. But also at the webinar last week, we had an opening session that brought together an endocrinologist with a dietitian specialized in obesity and as it relates to metabolic health. We had a hepatologist present NAFLD patient guidelines and then got a patient response on the NAFLD journey. So we're trying to really bring together different disciplines, different perspectives to get the person on the street perspective and then go beyond the liver space and bring in diabetes, obesity, and other related disciplines. Jörn?
Yeah, Roger, from my perspective and, 2 weeks or 3 weeks out of NASH-TAG, there's been so much advance in the field in terms of refining NITs. Think about NAIL NIT, the initiative Stephen and Mazen are spearheading, trying to get industry data pulled together to define NITs and look at the big spectrum. But if you look outside of hepatology, none of that advance, and it's been, stellar with regards to what we're talking about, is perceived at that level that we're discussing this. It's time to move this advancement in the field, diagnostics, special therapeutics, to the next level and get other healthcare professionals involved to be able to offer that to patients. Because we as hepatologists, we see that maybe the tip of the iceberg or the tip of the iceberg, but there are so many unidentified patients out there. We have to involve them in this discussion and bring them that advancement that we're seeing in the field here. And that's what was fascinating for me when Jeff came up with this idea, mainly from the public health perspective, but also from his view on liver disease, that there is ways to leverage on public health agenda and addressing additional healthcare professionals and get them interested in providing care with those novel diagnostics. That's at the heart of that webinar. Transform all that innovative data, all the phase 2, 3 results. We're making progress here in hepatology to take it outside and educate the field at a broader level.
When you say the field, Jörn, how broadly do you think that education needs to move?
When we're making the program now, we're talking about primary care physicians. This is where the patients are. They have a lot of patients and very little with advanced disease, but they should be comfortable to know that there is a disease that can give, let's say, 1% of their patients or make it 2 or 3% liver cirrhosis. And if you move into more specialty fields, I think we've actively engaged with type 2 diabetes physicians, but also obesity specialists or some other physicians, cardiologists. They're not aware of the type of tests we're using. Not even if you mention FIB4, a lot of physicians won't be able to tell you what that is. So I think we got to break it down into the information to provide them with the respective information. It could be what type of screening does a primary care physician need to know. They don't have to know about all MRE changes and peculiarities of the field, but they have to know what tool is in my population the best one and how should I refer a patient then, and why does the diabetologist send this patient back and prescribes this medication because of the concern of NAFLD in the background. You want to really make other healthcare professionals aware that this is a disease that needs management and how to identify it.
It's interesting what Jörn said. I mean, how, primary care physician may not, or even probably not in many settings, will know what a FIB4 is. And we need to think, one of the goals of our webinar and the hybrid meeting we're going to have in May is to look at innovations. And, there'll be a while when they don't even need to know what a FIB4 is, because that can be calculated and the results can simply be sent back to them. I mean, we're collecting the information to calculate FIB4, but then we're asking people at the primary care level to do more work and do the calculation. And simple as it is with the online calculator or tools you may have in your own system, this can also be done. And And there are initiatives that are starting to do that and then send that information back to the primary care physician who can say, listen, we were looking for X, Y, and Z, but we ran the following tests with your blood sample, and we need to talk about what that means.
What strikes me, right, is primary care should need to know enough, if not to do all the calculations, at least to know why they're done the way they are and why they matter and all that, right?
Yes, and that's a long educational process that we can't just sort of wait. I mean, it needs to be done in parallel.
And there are many different kind of learners category. There are people who can't learn something until they really get up to their elbows in it. So what do you think is the fastest or most effective way to convey that information so that the people that we're looking for will actually get it, as compared to hear it but not appreciate it?
I mean, there's issues about stressing the urgency, and the epidemiology will be incredibly important. And again, not just the numbers of people estimated to be living with fatty liver disease, but a little bit of innovative epidemiology. So look at the tsunami on diabetes, in obesity, in fatty liver disease, the relationship with cardiovascular disease. So they need to understand that they need to treat the patient, the person, and not just the individual conditions and disorders. That will be a first step in raising awareness. And the other is we need to speak less among ourselves, or at least speak as much among ourselves, but also speak to new audiences. So it's how do we get to have these kinds of sessions at national and international general practice primary care conferences? We need to engage with those stakeholders to find out what it would take to get their interest. Because if we tell them there's one more thing you have to do in that very short visit or your very long day, my guess is they're probably not going to say, great, tell me what it is. That's why some of the automated calculations are helpful, but they also need to understand what it means to be living longer and now to be living with liver conditions.
Yeah, in that vein, though, I think it's important to realize, well, we have to get the message out about fatty liver and the fact that 20 to 25% of people with fatty liver are going to be at risk of progressing over their lifetime and probably over the time that they're being cared for by that individual provider. Something like FIB4 is a good initial test today because of its negative predictive value. It lacks specificity for identifying the at-risk NASH patient. So it's a start point, and I embrace FIB4 for its start point. But let's not kid ourselves. It's the right plane. It's the biplane from the Wright brothers of a non-invasive test to identify the at-risk patient. It's a start point. It's not where we're going to end. Or at least that's my hope and prayer, is that we get much more laser focused on identifying the patients that are at greatest risk of disease progression. And not only that, the timeline at which they're likely to progress. Because right now we just say, if you have an abnormal FIB4 or it's indeterminate, chase it with another test, and that puts you in the at-risk NASH category. And those people have a variable rate of disease progression and a variable rate of progression to something like liver cancer. And we need to get more granular at identifying that. That's not really the purpose of, I think, what you're trying to do right now. You're trying to just build awareness about the disease and show that there is a test that is free, that can readily be applied to their patient population, and is essentially the 80% solution when used on a one-time basis, right? 80% of the time, you would exclude the people that don't have at-risk disease, or at least F3, F4 fibrosis, and then putting them back into the healthcare system with some sort of, ideally, digital therapeutic management would be the way to go, and then bring them back periodically for repeat testing. And as we get better at it, then we can refine that algorithm a bit more. But it took me a while to embrace FIB4 because of its issues. As a highly sensitive, negative predictive test, it is a good place to start because it's ubiquitous. And if you get liver chemistry tests, essentially, and platelets, you can calculate this.
Is there an opportunity with FIB4? And I know when you talk about your biplane and your fighter, we know there's a massive cost implication between really advanced technology and your fighter jet in comparison to your biplane. And when we talk about algorithms in health, the more specific we get and the more we find, the more people go, oh, we don't want to find it. It's a very expensive way to look. And I just wondered, we have National Health Service Health Check, which it's like sticking a small plaster over a gaping wound. You get your finger pricked to get your cholesterol, you get a blood pressure. It doesn't tell you much about the person, and we put it into a few algorithms. But if you were to take a set of blood where you could calculate all of the biggest risks for cardiovascular, type 2 diabetes, FIB4, so your major organs out of a couple of blood samples, and we could pinpoint the specific age range to say that this is going to capture the most people that are going to be at risk now and potentially at risk in the next 10 to 20 years. Is there a possibility to link something like that to NAFLD pathways in the future? We know...
You would hope so, but remember, this is what Theranos tried to do, right, with Elizabeth Holmes? and it did, it's a great idea, but I don't think our technology is there yet to do that on a couple pricks of blood from a population. But
we'll not even take the pricks of blood, but actually logistically really take blood off people in a specific age range to say that this is the volume of people who are going to get fatty liver in the next 10 to 15 years, or cirrhosis of any description, because we know the age ranges where people die of cardiovascular disease. We know the age ranges of people who are liver disease. In the UK, the average life expectancy is to 59 if you're diagnosed with liver disease, for example. So we would be, just off the top of my head, I'd be thinking of screening or looking earlier, which means you can have pre-printed results that say your FIB4 is X to guide GPs. So it becomes more of a holistic health check for big risks, cardiovascular, liver, diabetes, in a blood test rather than just paper over a crack, I suppose. Is there that opportunity in the future?
There's some truth to that, Louise. What we want to achieve is that the physicians that are interested, or the physicians we're going to involve, are aware of this type of tests and the concept of disease stages and fatty liver disease. Because when I talk to physicians here, you still get those, why should I worry about the liver? On the other hand, we know that it's an exponential risk in patients with cardiovascular disease. So how much does the liver add? And we really want to emphasize the need to do these type of tests, because if you have physicians that do get the report, but they won't act on it because the knowledge is not there, this is a major burden here, at least in the German healthcare system, where you have less NHS structured pathways. It's the physician has to act on something he receives and convey that information to the patient. And that's why I think that outreach is so important. We need all these other stakeholders to get on board.
Also, we're talking about primary care physicians, and yet even endocrinologists aren't all using the simple free test, Stephen, for FIB4. Yes, I think we need to be thinking about multiple approaches and at multiple speeds. So we can be raising awareness among primary care physicians, but we need to be raising awareness not only among cardiologists, but around endocrinologists and obesity specialists, because again, when we reviewed the strategies and action plans, they're not considering this at all. We're moving on two speeds now, which are basically stop and slow, and we need to be moving toward slow and intermediate. And I like what you said, Louise. That's long-term thinking that I think we need to be testing now, because at some point I hope we're at the point where we can implement that. But again, you can go to diabetes clinics around the world, around Europe, around in high-income settings, and they're not addressing fatty liver disease at all. So it's going to be a hard sell with a lot of primary care physicians.
So the question I have for you, Jeff, is why aren't they addressing fatty liver? So in the U.S., we would argue that what I'm told is we have 15 minutes to see a patient. We have to address all these HEDIS measures. I'm dealing with cholesterol. I'm dealing with A1C. I'm dealing with blood pressure. I'm calculating the ASCVD risk score. I'm sending them for their mammogram, for their colonoscopy, and talking to them about healthy eating. In my 15 minutes, I don't know when or how to add in a discussion about fatty liver. We make the argument, okay, well, this is diabetic hepatopathy. You talk to them about retinopathy, neuropathy, nephropathy. Why not add in a bit about the liver? Well, okay, so do we have any drugs to treat that yet? No, but we have lifestyle. Well, I already talked to them about healthy eating, and I focus on low carb, I focus on low fat, lean meats, and exercise. Right, okay, that's good. But do you set a target weight loss goal? And we kind of go in a circle. But sometimes it ends up back to, Dr. Harrison, I've never had a patient die of cirrhosis in my clinical practice. Well, okay, that may be true, but that's because they got sent to transplant and they didn't come back to you. And so there is this ongoing debate about, okay, if fatty liver is a real problem, how come I wasn't taught it in medical school? How come it wasn't taught to be by my mentor in my fellowship training? Then if it's a new problem, do we have drugs to treat it? This is like it's almost like a perfect storm. You want to keep a very simple message, because I'm a big believer in the KISS principle. Keep it simple, stupid. Let's boil it down to its least common denominator, make some glossies, and go out and talk to the world about the same consistent message. And that's kind of what we're trying to do with FIB4, because you can look at all kinds of algorithms out there. I'll raise my hand. I created the BARD score. Well, that's not used anymore. And my good friend Paul Angulo created the NAFLD fibrosis score. That's really not used anymore. But all these are kind of out there in algorithms. There's the RFE. There's lots of things. So if we could finally come to an agreement that we're going to advocate for one score as the first test, understanding that the best way to diagnose these patients prospectively is with sequential testing. But that's really not the target today. It's excluding the people that don't have disease, and those that are in the indeterminate zone or abnormal zone, there's another opportunity for them to get tested further. But we need to have a very simple message. We need to be uniform in the way we deliver that message. And let's be honest, it's going to help when we get our first FDA approved treatment, because now we've got something to hang our hat on and we can build from there. But it doesn't mean we can't start to build that foundational, consistent, all marching to the same beat, the same drum now as we look forward to the first therapy. Because I think at that point, like in anything, there are watershed moments where we ramp up in our educational opportunities and we ramp up in the utilization of whatever we're trying to use or assess. We'll have that first big step with the first drug approved.
Stephen, thanks for that. You brought a question to mind that I want to throw out to the group, which is that if we're trying to get a simple message out, the simple message should have a simple endpoint. What are we trying to do here? We're trying to get liver fat down? Well, that's vague. I don't know where I'm trying to get it down to or what am I trying to avoid. So the question becomes, to me, on one level, becomes, what am I doing this to avoid? In that regard, as we're starting to go out now and figure out things like what would you do with targeted messaging at different specialties, I get two sets of feedback. I get people who say, all you want to talk about is cirrhosis. And then I get people who say, oh no, talk about cardiovascular, talk about metabolic issues. And it really is two different diseases. I'll ask, first of all, Jeff and Jörn, in the context of what you're working on this year, and then more broadly, all of us. So what's the endpoint? If we're trying to get people a simple KISS endpoint, what is it? What are we trying to avoid here?
I mean, I think we are trying to avoid advanced liver disease, cirrhosis, end-stage liver disease, liver cancer. And the way to do that is to know if people have too much fat in their liver and what their fibrosis stage is. And Stephen, you posed a question and then you also answered it, and I fully agree. But there's also, I feel like, a moral obligation that people should know that they might have a liver problem. There's all sorts of other health issues that are raised with them, and liver should be on equal standing with people so that they're aware. We don't have great tests. Well, we didn't have great tests for COVID, and we didn't have great treatments. Obviously, it's very different being an infectious disease, but people have a right to know. And as physicians and public health experts, people in the system, we need to raise the awareness that there is this, tsunami, this huge number of cases out there that people are unaware of, and that there's a huge interplay. So Roger, you asked about metabolic health. People need to know that there's other things at play. It's not just to approach everything in silos, but it's to consider, again, the whole of system approach. I talked earlier about the whole of society approach for fatty liver disease policy, but we need to look at the whole of system approach for individuals. And if primary care physicians are too busy, and I appreciate that, and I think they probably are too busy, there are automatic calculations that can be done. And as I said earlier, we can also, while we're slowly raising awareness with them, be targeting those who need to take urgent action, which would be endocrinologists.
Yeah, it's interesting just thinking about this a bit more. On my plane flight home yesterday from Paris, one of the flight attendants, and by the way, Naeem Al-Khoury was sitting in the seat right behind me. I don't know what made us look like liver docs, or maybe she overheard us say something about the liver, but she stopped us and said, "Do you guys know anything about fatty liver?" And Naeem and I looked at each other and said, "A little. What's on your mind?" And she said, "Well, I've got this wonderful Jordanian friend who is a little overweight and maybe diabetic, and was told she had fatty liver and was basically told, don't worry about it. There's nothing you need to do." And she was telling me about it. And I I began to look around on the internet, and sure enough, this could be a problem for her, right? I said, yes, this could be a problem for her. How old is she? Well, she was 60. And I said, so she's a postmenopausal female, overweight with potentially diabetes, and from a really high-risk ethnic background. She's like, well, she's visiting me in Dallas. Is there anywhere I can go to get checked? And what check would you recommend? And Naeem and I looked at each other and said, do we know anybody in that area that would be able to put her through, the appropriate testing and refer her to the potential right place to go? And just to be honest, we couldn't think of one. So we both gave her our card, and I said, drive 5 hours, bring her down to San Antonio, and we'll do a free fiber scan and we'll put her through the appropriate testing. But at a minimum, you should look at the liver chemistry test. And we didn't talk about FIB4 because I think that would be a little maybe not appropriate in the middle of a plane to talk about what FIB4 is. The reason I'm bringing this up is because I think the patients are beginning to sense that there is something with fatty liver, and that when they go to their provider, they get falsely reassured that there's nothing going on. And so that just reminds me that we have to do this in parallel. We need to bring the patient awareness. But if we send patients forward to the physicians and they're turned away, that doesn't do us any good. So we have to, at the same point, we have to educate the physicians. But imagine if all we did was educate the physicians and we didn't teach the patients that there's a legitimate problem. We're kind of in the same boat the other way. So it's a dual-headed effort to get after patient education and physician education.
Fully agree. Jeff is going to probably say that one of the aspects we're going to throw in there is going to be to have patient involvement in an advocacy group or patient perspective. So that's clearly very important. And the other thing, just to mention briefly, because you asked of an endpoint and listening to Stephen and Jeff, for me, the endpoint is an at-risk of liver disease patient, or call it at-risk liver disease patient. That will be redefined over the next years. But I think we got to push for that endpoint to identify the patients that will get in trouble for their liver and educate our peers on how to identify them and manage them or refer them.
And I was just going to add that thank you for telling us that story, Stephen. It must have kind of been awesome just sitting there, when someone asks you if you, of all people, know anything about fatty liver disease, and kind of you to offer to take care of that patient. But there's way too many to be doing this on a one-by-one, case and offering free fiber scans. The very first talk at the webinar was the new NAFLD patient guidance, the first set of guidance, developed for patients in lay language, developed by Sven Frank with many experts and patient representatives involved. One of the big problems we have, aside from not having the treatments beyond, lifestyle interventions, is not strong or well-developed liver patient groups. So weak advocacy groups, weak groups raising awareness in so many different countries. So many countries have no patient group at all. Diabetes groups, cancer groups don't usually address liver health issues. So I think we need to be taking this sort of top-down approach, if you think maybe more from the health system and the specialists and clinicians, and going into GPs, and then the bottom up, which is educating the population, but also even educating the patient groups themselves and helping to develop them. Because that was one of the successes in viral hepatitis, was when Charles Gore and others at the European Liver Patient Association, which is only around 15 years old, said we're actually going to help create new liver patient groups, primarily focused on viral hepatitis, in countries where they're needed. And they often called on medical professional organizations to help in that process. And that's what we need to do for fatty liver disease.
I agree with you all. It's also about liver health. We need to make livers more attractive in the context of, if in doubt, rule it out, because your liver is expensive to every other metabolic disease if you haven't looked at it. And I've heard the argument that NAFLD should be an endocrine disorder or a cardiology disorder, and NASH is the liver disorder of that. So maybe we need ownership in different areas. The reason I really think it's important now is we are in a pandemic. We have a really big rise in weight around the world. And I looked at some figures today that if we don't start to get this out there, and maybe there is the opportunity with people becoming aware of how badly the diet has changed through COVID. And the government here have launched a campaign for improving children's diet this month, and they have a new app where you can scan the food and it will give you a healthier opportunity because it assesses the food as you purchase it in the shop. But some of the figures that came with this are really alarming, that 1 in 4, so 27.7% of children of reception school age are now overweight or obese, and 4 in 10, or 40.9% of by the time they're 11, are overweight and obese. But in highlighting those, 27%, it was nearly 6 in 10 parents are now feeding their children more fatty and sugary snacks than they did pre-pandemic. And nearly 2/3 or 64% of parents said they often worry about how healthy their children's snacks really are. They buy them. If they don't know how healthy those snacks really are and can't tell, which is one of the reasons that 90% of those parents said that they'll benefit from the app. But also those parents are probably eating those snacks. Now we can wait for research to prove in 10, 20, 30 years that the pandemic blew out NAFLD and NASH and wait for that. Or we can look at the programs that Jeff and Jörn and people are trying to start to try and raise this awareness. But it's hidden. It's talking about improving children's diet. It's hidden in a weight loss app. It's hidden in improving weight for diabetes. And they use the same mechanisms we do. We just need to be now overtly using the same language. Charities for diabetes need to talk about fatty liver disease, but they don't. Charities for cholesterol need to do that. They don't. We need to look at the language. We're avoiding the biggest disease. I know Jeff's keen on the SDGs. The elephant in the room on the plateauing in a lot of cardiovascular diabetes, the numbers rise, but the improvement in health means we treat more, but we're plateauing. The elephant in the room is probably the liver, and we still don't talk about it. But the figures coming out now with weight gain and alcohol increase, our liver has taken a pounding with COVID, let alone being involved in the outcomes of COVID. So what you're trying to do and involve them has never been needed more.
I sympathize, Louise, and although we've been saying we need to engage with endocrinologists and even cardiologists and obesity specialists, in a way I wish the public health specialists for a little while had the upper hand and somehow engaged with the infectious disease specialists to say one of the other things you can do to help your COVID-19 outcomes would actually be to watch your diet and to exercise more. I had this kind of dream, apparently, that maybe countries and governments would take that on. Maybe there would be TV and radio programs, certainly during the first year when things were so hopeless and there were no treatments or vaccines at all, and remind people that here's another good reason to watch your weight, to exercise more, to take care of your body. But we failed miserably, as you just described, and things actually got worse in so many ways. We'll see it soon in the epidemiology on liver disease, and particularly fatty liver disease. I think it's just going to be so much more worse.
Just a point on that. Mike Charlton showed a pretty nice graphic at NASH-TAG on the COVID pandemic, and it's linked to BMI in the United States. And this comes from the Morbidity and Mortality Weekly Report that's published, showing a doubling in the rate of increase in BMI since COVID. So, I mean, it's happening right before our eyes.
And just to pick on what you were talking about earlier with people now taking initiative themselves as patient, you described the lady on the plane. I've heard the conversation in the hairdressers. There is a scope of people who are aware of it and driving their own health. I saw somebody last week who'd taken themselves to have an ultrasound that showed an enlarged fatty liver, who then decided to take on the next step, having discussed with the British Liver Trust, which was a FibroScan. Surprisingly, didn't change any of what we'd seen at the ultrasound. It was a little bit stiff, it was quite fatty, but their first NHS appointment's July. So by now having that information at their fingertips, that should lead to an expediting of that appointment with a hepatologist. So people are taking control, and we're seeing a lot more people now requesting them on waiting lists, and we give the money back. If your waiting list from the NHS sees you earlier, then cancel your appointment, you get it back. So people are now driving their own liver health, which is important. So there is a side and an element of really well-informed patients and proactive, but it's not enough to change the world in the way we want, and Jeff describes at the moment and Jörn are trying to do. But I think there's small steps, as they say.
I think that's right. But I also believe if you go back to the U.S. data, and this is a global phenomenon, not just a U.S. phenomenon, although we may have it worse than a lot of other places do, a bifurcation of the population into significant proportions that have simply we decided not to believe in any of this. In the U.S., that number is probably about 30%. Don't believe in COVID, don't believe in vaccines, don't believe in doctors, don't believe in anything that they aren't told by someone on Facebook or whatever, by somebody who isn't on their side of the issue. Is the challenge going to be to work with people who want to hear the story, or is the challenge going to be to work with people who need to change what they're doing, even if they're the ones that don't want to hear the story? Or is it both?
Like I said, we move in parallel speeds and we need multi-pronged approaches. I mean, right now, for the people who do want to change their life and who are at high risk of fatty liver disease, we're not even doing enough. And there's such a high estimated prevalence. Stephen said earlier, maybe 20 or 25% of the adult population. There's so much work to do. There's enough people to go around. So although there will be people who are resistant or reticent or disbelieving, they're at the end of the line. We're not even, like I said earlier, and we know, reaching the obese population that's going to a GP, people with diagnosed diabetes. So there's so many populations to start with, Roger, that I think we start with the so-called low-hanging fruit, people who want to hear about their health and how to improve it. When they hear that here's another good reason to take care of yourself. Some people will take care of themselves for their looks, and some people think it'll give them a longer life, and some people are worried about cardiovascular disease or are managing their diabetes. Well, now here's another reason. We start with that population and then move forward. The same way with COVID-19, we started vaccinating everyone who wanted to get vaccinated, but we told everyone in the world the importance of vaccination. Now we have the evidence that it works, and now we need to move towards those who are hesitant, knowing that that hesitancy is really a sort of a scale, and there'll be a smaller population that's completely resistant and others who have different doubts that we'll need to address in different ways.
That's great, Jeff. Let me turn that a little bit. We've got 6 or 7 different kinds of people that listen to this podcast. And if I tick them off group by group, I wonder if there's advice for any of them you would have, Jörn would have, any of you would have, that's specific to who they are and what they do as compared to the general stuff we're talking about right now. Okay, about 40% of this podcast listeners work in pharma or biotech companies. Of those, split more or less evenly between people who are in a clinical function and a commercial function. Is there advice you'd have for those folks that would be different than what we've talked about so far in terms of what they should be doing, what they should be pushing their companies to do, their families to do, any of that?
That's not an easy one, Roger. I'm going to say something quickly, and Jeff has more time to think about a good answer on that one. It's the awareness issue with the medical field. If you aim to position a drug or a diagnostic test in the field, it's important that the physicians ordering the test perceive the benefit for their patient, or that the patient is aware test is there so that they can order it or buy it for their benefits. Clearly, this is where we want to go. We want to implement the innovations that are there for the care of the patients and make the involved physicians aware. That's what it comes back down to. The colleagues in pharma are one stakeholder to propagate that awareness. And as Stephen said, I think once we have therapy, that will be much easier.
Thanks, Jörn. And I would compare the situation a little bit to hepatitis C. We didn't have good therapies for a long time. And when we did, we started treating the so-called warehoused patients, everyone we knew who was diagnosed and needed treatment. And then we started having this diagnostic burnout with, the vast majority of the estimated population of people living with hepatitis C undiagnosed and therefore untreated. We realized we don't know where they are. We're not finding them. We're not diagnosing them. We're not bringing them into care. So awareness needed to be raised on a lot of different levels. So we're targeting policymakers about why this is important, why this makes sense from a cost perspective, and to the general population. It's different because it's an infectious disease, but in the case of fatty liver disease, there's such a high prevalence and such a strong interplay with other conditions that it's such an urgent matter that we need to be raising that. On the other hand, I'd throw back to the hepatologists among you. If we did have huge success and next year people said, wow, I'm really worried about fatty liver disease, and started flooding primary care, and you started getting all of these people sent to you based on FIB4 or even just sent directly because they weren't able to take care of primary care, you'd probably be overwhelmed. So we have to get the balance right in what I think is a moral duty to inform people about this condition, and at the same time being able to make sure the health system can handle it, particularly during the COVID pandemic.
Louise, Stephen, thoughts on that? I can give you a couple of more groups I'm interested in.
It's been described, but I think there is inertia throughout the system. We've got an inertia with the healthcare system. We've got doctors who don't realise this is an important disease. We've got specialities that don't recognise it. So we then have patients who are similar, that this can't be an important disease. We've described it earlier. It's simple liver fat. You don't need to worry about it. And there's inertia in the whole system. We don't don't believe that this is a disease. So we are fighting on all fronts a mass of inertia. And how do we start to break that down? Now, industry and pharma can be very proactive here. If you start to target an education program to your primary care physicians, people are going to ask, well, why do they think it's important to teach me about this? There must be something behind it. It helps your diabetic population. It helps your obese population. It helps all of the populations that you see as a problem. Alcohol, viral disease. By targeting education about liver health and how it impacts your care and how it impacts how you care may start to change that inertia. Because unless we see how that can save the money in our pockets, yes, we can find more people, but we find them earlier to save more money in our pockets. And I think it's the right quality person that needs to be sent to a hepatologist. It's the right quality patient needs weight management and obesity care. We can separate that out with the non-invasive technologies that we've got now, but we need to break the inertia in each of the groups at the same time, or to start one rolling that causes the inertia in the other groups to move. It is not an easy task, but pharma could play a massive role in that.
I'm realizing we're getting towards the bottom of the hour, so I want to take this in a slightly different direction than I had in mind in respect to everybody's schedules. Jeff Jörn, what benefits will people who attend the May event do you expect they will get out of this, and what is your best pitch to them about why they want to be there as compared to why you want them?
That's a good question. What are people going to get out of attending a meeting on innovations in NAFLD Care? They're going to get a multidisciplinary approach. They're going to get the top experts in the world delivering state-of-art lectures from different perspectives. They're going to hear about developments in non-invasive tests, but also developments in weight management. They're going to get a chance to hear patient perspectives, and they're also going to get a chance to participate. We'll have some polling, we'll have questions, we'll have different ways to engage in addition to the questions and answers that they'll be able to have for these sessions. It's going to be a fun meeting, so it won't be death by PowerPoint. We're going to try and engage with each other. We're going to try and engage with the audience.
Oh, and just to add to that, this is not just going to be another NAFLD meeting. It's going to be the place where we hope to engage everybody and really move all these innovations that are coming out of the specialty meetings to a broader audience and scale to get everybody involved and have, in the end, patients benefit from all that progress that's been made in hepatology.
So, Louise, Stephen, what would you like to ask these guys, or what comments do you have about the program based on what we've been talking about for the last 45 minutes?
I'm looking forward to seeing whether or not there's any coordination of the nursing care. And given that nurses make up the majority of the workforce, and we know that adding nurses into pathways, diabetes are doing it quite nicely. There's some more evidence coming out of there about adding nurses or allied health really improves the outcomes. So I'm excited to hear what you guys are going to say on that perspective, and it will lead to what I will be talking with some of the nurses next week.
Well, we look forward to hearing what you're going to be discussing next week, because hopefully that's going to feed into our program. And I don't think it's going to necessarily be
cheating.
Well, I don't think it's going to be Jörn and I necessarily speaking about the nurses. It's going to be you or someone you suggest.
The thought I had was, we've been talking about how we're not going to get to meet Louise for the first time until EASL. And the immediate thought I had as I listened to her was, no, we're all going out to dinner in Barcelona in May.
You're all very welcome. I'm cooking.
Assuming we can get there. Stephen, do you have a question? If not, I'm going to ask Louise to take a couple of minutes and talk about what next week's episode is going to be, because it's going to be a little different.
Maybe just a thought. If I were designing this conference, one of the things I would want to have is a fireside chat or a roundtable discussion with a multidisciplinary group where you could ask the hard questions. And that would include patients. So you would have patient representative, endocrine, obesity management specialist, primary care, family practice, maybe even grab a podiatrist. Believe it or not, podiatrists see a tremendous amount of fatty liver disease because they manage the diabetic foot ulcers and the complications that go with it, as well as they manage foot fungus, toenail fungus, and they have to prescribe Lamisil. And before they do that, they have to check liver chemistry tests. And they often find them quite elevated and don't know what to do with the patients. Having said that, I would have a panel of 5 or 6, 7, 8 different specialists and patients, and I would pose the hard questions, the questions that we talk about on this podcast, the questions that are brought up in public forum, and just have a dialogue about what the challenges, the hurdles for each, and they may be different for each one of them, but collectively you can begin to craft the narrative on what needs to be done to leave a big fat dent on this planet in the name of fatty liver.
Thanks, Stephen. I think that's great. And having seen how effective fireside chats can be recently, I totally agree with you. easy on that one. Let's let Louise talk for a couple of minutes about next week, and then I'll go back to Jörn and Jeff for a closing comment, and then we'll check out. Louise, go ahead. What are we doing next week? What are you doing next week? I'm not going to be there.
Well, to be fair, what we're doing, or what we're hoping to do, is cover some of the Lancet Commission. It was prominent in the Lancet Commission that they talked about the RCN competency document as being the only one in the world to look at the standards and quality of care that we as nurses should be given to liver patients. Now, what we want to discuss, we've got Michelle Clayton, who's one of the authors of the original and follow-up RCN guidelines, to look at the benefits and the strengths and weaknesses of those. What we want to do is say that these can be utilised around the world to enhance your care of liver patients and adapted. And we want to look at how that can be done. We want to look at the discrimination in healthcare by not having anybody who's a liver specialist from either a hepatology or gastros perspective in a hospital, or particularly nursing areas. It is very difficult for a doctor to look after a patient who's encephalopathic if the nurses on the ward aren't trained to recognise encephalopathy or ascites. So by not having any strength in any area, particularly we use the UK as a setting, but we're looking at how we can use these to support that and to reduce the impact. We've got Dr. Catherine Jack, we've got Patricia Kunzler from Switzerland, and we've got Pam O'Donoghue, who's one of the leading cancer nurse specialists nurse consultants in this country, talking about cirrhosis and the management of different tumours. This follows on from what Scott Friedman and Donna Cryer were talking about last week, and that different tumours in the liver require different therapies and how we get these patients through. So what we hope people walk away with is one of your underutilised colleagues are your nursing team. They are your strength if you use them as a strength, because they can empower your patients. And I think from a clinical trial perspective, a 20 to 30 minute conversation that a nurse specialist and advanced practitioner can have with the patient is probably very informative to get them into clinical trials, instead of the 5 or 10 minute that a doctor has to do everything. There's a better understanding of informed consent. There's a better understanding of your patient portfolio. So how we can utilise the strengths of nursing colleagues around the world to impact clinical trials in NAFLD and NASH, as well as the care of the patient. So those are the sort of things we would like to be bringing the science, bringing the academic side of the nursing processes, and how we can adapt those throughout the different countries that listen to this podcast, whether we can twin, how we can help support, particularly when we look at care pathways that Jeff and Jörn and everybody are talking about. How do we mobilise the strength of nursing throughout the world? Because if every nurse found just 5 people with fatty liver disease, and they meet them every day, we would actually turn around this tsunami. But by looking in those basic questions, the power is there. We just need to find a way to utilise it, to get that inertia, get that going. So hopefully we'll give some stimulating discussions and some thinking, and let people take away a lot of thoughts. Hepatology nurses are an asset, and they can save money, but they save patient time, but they allow our medical colleagues to really enhance their work. So I hope that's what we're going to be discussing.
It should be a fascinating session.
I was going to say, I think I'm intimidated to be a part of next week's podcast.
I'll recommend it to my entire team.
Good, and that's what we want. We want nurses listening to Surfing NASH. Surfing NASH is some of the best technology, the best innovations, the best research in the world. We should be listening. I would say that to all my nursing colleagues, not just medical colleagues, just not science colleagues, but allied health colleagues. We need to know this is coming, because we need to plan how these pathways are going in 5 and 6 years' times if we get medication through, or even now how we can maximise lifestyle. So, yeah.
Louise, that was amazingly compelling. I'm thinking you need to write a pitch that Jeff can use and Jörn can use as well when talking to some of those audiences, because you boiled it down really neatly and really cleanly. You should be able to sell people who go to Barcelona and everything else.
Well, you said I was a host, so I had to. Normally I'm not the host. I don't have to drill it down.
You just taught me a couple of things. Actually, Jeff, you're on closing thoughts.
Thank you for the opportunity to say a few words about our webinar, the coming meeting. I say our in the broad sense. This is a multidisciplinary event with a lot of people involved. I think it's been a long time coming. It'll be complementary to the other liver health and NAFLD and NASH meetings that are out there. We just want it to be an open forum where people can share and learn. We want to emphasize even implementation and operational issues, in addition to some of the state-of-the-art talks that'll really be the scene setters to get those discussions going. It's 6 sessions split over a Friday and a Saturday in Barcelona in May, so it's not the worst setting to be in, but we also respect that some people won't be able to travel, so we'll have it as a hybrid meeting. We hope that we're going to try and have all the speakers travel so that those who do come can engage with them. But we're excited about this because, just like Louisa put out there, I mean, we need to engage not just the nurses and the primary care doctors and the endos, but so many different specialties and the patient organizations themselves, so we can start to, slow down the force of the tsunami.
Anything else to add on top of those two rather remarkable sets of comments?
Oh, I think they hit the ball out of the park, as you say in the US. I'd be happy to have you guys there and engage and meet, and really looking forward to that. And we're just finalizing the program, so be on the watch out for that.
I think this would be another great meeting to host a podcast from.
We are a media partner, and that is part of the plan, is to do that. And actually, I think that's exactly right. Of course, Stephen, that means you're going to have to go.
Yeah. Stephen, you were in Paris and you didn't come to Barcelona. What's that about?
Well, we talked about Barcelona for sure. And I could definitely do Barcelona in May. COVID or no COVID, I'm traveling.
By then, there won't be much COVID, I can tell you. We have infection rates that are completely out of control. So by then, there won't be many more people to infect. And we're also one of the most vaccinated countries and soon to be one of the most boosted countries. Things are rough right now, but by May, we'll be ready for you.
The biggest challenge to travel is the disparate amount of information that's out there on what you need to have to get on an airplane. It's crazy wild what you hear and what reality is. That's scaring a lot of people from traveling. The flight I was on yesterday had 100 people on it. It's a big 787. It seats 300 people. So
I agree with that. And I mean, going to the UK right now is still very confusing. But Spain has been driven by its tourism industry and basically said, throw caution to the wind. You don't need to get tested. You barely need to get vaccinated. So I think you'll be covered. But we'll definitely share that information in advance.
First of all, Jeff, Jörn, thanks for joining us. Louise, Stephen, I thought last week's webinar was really enlightening. I'm looking forward to the meeting in May more than I can tell you, not just because I love Barca, but because the meeting in and of itself, I think you could put this meeting in a dungeon and lots of people would want to get to it. You don't have to do that, but you could. So thanks for coming on and talking about it today. Next week, as I say, I will be on vacation. Louise will be driving the boat, and I will be back with all you folks in 2 weeks. Actually, I'll be back in a couple of minutes with a business report. But thanks, everybody. Enjoy the rest of your days. And talk soon. Okay, thanks.
Thank you.
Thank you so much.
Okay, bye-bye.
See you. Bye-bye.
bye again.
Welcome to today's business section.
Doesn't that program in Barcelona sound really exciting? I think Jeff and Jörn did a tremendous job of explaining the reasoning behind it. And as I mentioned, Surfing the NASH Tsunami is a media partner with Innovations in NAFLD Care 2022 for the whole series. And we're hoping to have a role to play in Barcelona. Certainly, as Stephen pointed out, we will do a session from there. That should be a lot of fun. The rest of today's business report is just the usuals, a little bit about listenership, a little bit about what's in the vault, and a little bit about what's ahead, at least as far as next week goes. So why don't we start there?
Listener numbers this year are off to a flying start.
If I said this at the beginning of the podcast, please forgive, but I'm going to do it again because it's so amazing to me. Before the end of September, we had never had even 3,000 downloads in a month. In the fourth quarter, we thought it was pretty remarkable in that we had about 4,000 a month. This month, we are already at about 5,400, and we have a week left. It looks pretty clear that we will go over 6,000. Now, some of that's about NASH, and some of that's about end-of-year content, but a lot of that's just about people going back and listening to old episodes and pulling things down. When we get to the vault in a minute, I'll talk more about what's in that.
We have something really special coming next week.
Now, this I did mention on the podcast. When I go places, people ask me, what is Louise like and why doesn't Louise ever host? Well, Louise is great. You know that. But next week, Louise will host. And when I knew that I was going to be off on vacation, I asked if she would come on and do a program about nursing and associated professionals and the important roles that those folks play and will need to play even more going forward as this liver pandemic arrives. She's assembled a fantastic international cast of people, and she has Stephen throw spitballs and make constructive comments both. And I think you folks are in for a real treat. I will be back Tuesday in time to edit it and pull it and do all the post-production work, and I frankly can't wait to listen.
The vault has a lot of same old, but some surprises as well.
So as I mentioned over the last couple of weeks, people have been going back and listening to a lot of old episodes or older episodes in addition to the new ones. This past week, in honor of NASHTAG, I guess folks went back and listened disproportionately to NASHTAG 2021, EASL 2021, AASLD 2021, even the fourth Global NASH Congress coverage that we did back in March got a lot of attention, more than any of that had in a couple of months. People paid a lot of attention to the interviews that we did as part of the 20K celebration last June. The interviews with Jörn and Ian Rowe and Stephen and Naeem and Donna Cryer did quite well. Not surprisingly, the best episode of the week, again, was 46.2, the conversation from Paris NASH. But instead of being up around 90 a week, which it had been previously, it fell down to about half that, 43, as of 6 o'clock on Monday. More recent, or episodes from a couple of months ago that did really well this past week, included the NASH patient-focused drug development coverage, did quite well. The subsection from the liver meeting 57.1, where we talked about how to put a big fat debt in NAFLD and NASH, and the wrap-up conversation did quite well. And also doing well was the first part of the NASH cirrhosis conversation 58.1, focusing on NASH cirrhosis, why it matters, and what the reverse results at AASLD had to tell us about drug development going forward from there. Beyond that, people listen to just about everything, particularly everything that's been done since December, did quite well. You're not spoiled for choice here. You got plenty of different things you can listen to and be happy with. I will note that episode 3.4, which was the 7-person wrap-up from NASHTAG, is the fastest out-of-the-gate episode in the history of the podcast. So if you haven't listened to that one yet, you might want to do it. It did exceptionally well and far better than any of its conversations. So that's a place where I would probably go for the whole episode. That's everything I got for you right now. And then we'll be back in 2 weeks with some really cool February programming. Hopefully some of our old friends will be back on. I'm hoping to put together an episode on NAIL NIT, the initiative out of NASHTAG that we've been talking about a bunch. And we'll be getting ready for the spring and exciting things to happen then. So I will be on vacation from Friday through Tuesday. And everybody have a wonderful weekend. Stay appropriately warm, cold, dry, wet, whatever it is you're trying to do. And I promise I will relax, take a deep breath, and think of the listenership out in the ozone as I have a chill weekend. So until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.